I hope to make this an interesting and dynamic 2.5 hours. The goal is to go through hematology, then take like a 1-minute stretch break in the seat, and then power through oncology, and then there'll be a break afterwards, and then opportunity if any of you want to come up and ask questions. My primary goal today is to try to take some of the mystery out of hematology and medical oncology. I hear common feedback from a lot of test takers and physicians in practice that they don't understand it or they don't look forward to it. It's the section of the test they look forward to studying the least. And so I want to make it simpler for you. I want to give you a foundation for how to approach these questions and how to approach these cases, because hematology and oncology together is now 12% of your board exam, and that has increased from previous years. Tony and I were just talking about that, and so it's not going away, and you also are seeing more of it in your practice. There's more than 15 million cancer survivors in the US alone now, and that number is expected to only go higher. So it will help you to have a working familiarity with it, and that's what we're going to try to do today. First, with hematology, I'm going to divide the discussion into basically thirds. The first third, I'd like to go over red cell disorders, primarily anemias, but also a word about hemochromatosis. And then in the middle third, we'll talk about disorders of hemostasis, bleeding disorders and clotting disorders. And then for the final third, we'll wrap up with bone marrow disorders and hematologic cancers. And we'll go over myeloproliferative neoplasms, lymphomas and leukemias, and plasma cell disorders. And again, take some of the mystery out of it, leave you comfortable with how to recognize what kind of patient each one of these diseases will look like. So with red cell disorders, anemias is something that we're all pretty familiar with and probably see regularly in our practice. You want to determine the type and look for the underlying etiology. Iron deficiency anemia is the most common cause of anemia, and the presentation typically will include general symptoms of anemia like fatigue and weakness, but then also clues that you're going to be looking for iron deficiency, such as occult blood loss or insufficient dietary intake or increased demands of pregnancy. There are some peculiar signs or symptoms that can present with iron deficiency, such as unusual cravings for ice or for dirt, as well as restless leg syndrome, particularly at night. If you see that, you want to be thinking about iron deficiency. Your blood smear and your CBC indices will be pretty characteristic. You're going to have microcytic and hypochromic red cells, and so what that means is that your red cells are smaller and paler than they should be. This is a typical blood smear where there is, at the center here in purple, is a lymphocyte. And that's going to be your barometer, because an average red cell should be about the size of your lymphocyte. And so if you see some cells that are smaller, like you do here, those are going to be microcytic cells. Furthermore, if you see that the central pallor is increased so that more of the cell is white, that is hypochromia, also a clue for iron deficiency. Your retic count is going to be low because this is a hypoproliferative, right? It's an anemia of production and maturation. And you'll often have an elevated platelet count, and that's a reactive thrombocytosis that can be seen with iron deficiency. That's an important point. You may be presented with a case where you're given a CBC and the hemoglobin is 9 and the MCV is 71 and the platelets are 600, and you look at it and you think, oh my God, there's something really, really wrong with this person, like leukemia or... No, it's iron deficiency with a reactive thrombocytosis. So recognize that so you don't go off on a wrong tangent if they're giving you certain answer choices there. The gold standard for diagnosing iron deficiency is a low serum ferritin level. It's the best test to assess your iron stores, and a level less than 40 is considered consistent with iron deficiency anemia. But recall that ferritin is an acute phase reactant, so in inflammatory conditions you may have an elevation in your ferritin, and so you have to kind of interpret it with a grain of salt there. Once you've diagnosed iron deficiency anemia in the appropriate patient, based on the signs, symptoms, and blood findings we've just discussed, you're only just getting started, because the real sort of heart of the matter is figuring out what's the underlying etiology. So it's listed here in younger females. You think about menorrhagia and menstrual blood loss. In older adults, occult GI blood loss unless proven otherwise. And in other cases, rarely, it may be an issue with poor absorption of iron, such as in chronic intestinal absorption states. So if you're given an older patient who presents with a microcytic anemia and a ferritin of 8, and they ask you what's the next best step, check stool for occult blood, colonoscopy if they've not had it, look for occult blood loss. Treatment for iron deficiency is fairly straightforward, PO, or in some cases IV iron replacement if you need a rapid response or if there's poor tolerance to oral iron. Typically it's going to be GI side effects. So that brings us to our first audience response question. And we have an 18-year-old female who presents complaining of fatigue. She describes normal menses. On exam, she's pale, her hemoglobin is 10, and her MCV is 70. Her platelets are slightly high at 450. Her serum iron is low, her TIBC is increased, and her ferritin is low. Her iron saturation is 10%. You treat her appropriately with oral iron after diagnosing iron deficiency anemia, and she comes back, let's say 3 months later, and she's feeling no better. She's fatigued, she describes some nausea, her bowel movements are dark and voluminous. She swears to you that she's taking her oral iron. You repeat a CBC and it's unchanged. Hemoglobin of 10, MCV is 70. Which of the following is the most appropriate next step in management? A Coombs test, an HIV, an IgA trans-tissue glutaminase, lecturing her about doing better with taking her iron supplements, or checking a serum haptoglobin. What do you guys think here? Okay, and that's pretty good. So more than half of you correctly recognized that this is celiac sprue and thus checking an IgA trans-tissue glutaminase. So the issue here is you have a young woman who you're given no reason to believe has excessive bleeding and has persistent iron deficiency refractory to oral iron therapy. And so in this case, if it's not going to be blood loss to explain it, it's probably going to be malabsorption, and you want to think about celiac sprue as a very common cause of iron deficiency in otherwise healthy young people. Anemia of inflammation. It used to be called anemia of chronic disease, typically seen in cases with infection or inflammation, malignancy, trauma, heart failure, diabetes, and in elderly patients. And in this situation, you have enough iron, but you just aren't using it properly. It's impaired utilization of iron, and it's mediated by interleukin 6, which increases hepcidin, and basically hepcidin interrupts the absorption and utilization of iron in the body. And so the net result is that you have an anemia, and it could be normocytic or it could be microcytic. At quick glance, it could look kind of like iron deficiency. Your retic count is also going to be low, but there's some key differences. Because there's inflammation, your ferritin level here is going to be high. It's a key differentiator from iron deficiency. So if they give you a hemoglobin of 9.9 and an MCV of 77 and your ferritin 600, think not about iron deficiency, but about anemia of chronic inflammation. And your TIBC is going to be low here. You can check inflammatory markers like a CRP and sed rate to help you support the idea that there's inflammation. Rarely would you do a bone marrow biopsy, and the treatment is really just treating the underlying chronic condition. In some cases, you can use erythropoietin, although that has fallen out of favor due to some issues with toxicities on EPO that we'll talk about. So comparing and contrasting iron deficiency anemia and anemia of inflammation, you can see here the key difference is that the ferritin level is low in iron deficiency and it's elevated in anemia of inflammation. And the TIBC, it's flipped. It's elevated in iron deficiency anemia, low in anemia of inflammation. If you got that right, you'll never miss a question on microcytic anemia where you're looking at these. Anemia of chronic kidney disease, we're all familiar and recall it's related to decreased EPO production from the kidneys, which leads to decreased production of red cells from the bone marrow. This anemia in kidney disease can be treated with erythropoietin stimulating agents. It's important when you do that you screen for and treat any iron deficiency. If you don't replace iron, the EPO will not work. And so there's parameters listed here. You want to make sure your iron sat's more than 20% and ferritin's over 100 prior to maintaining on erythropoietin. And the other key point here is you do not want to overcorrect the hemoglobin. In years past, we would treat these patients with EPO and hemoglobins would go 13 and 14 and they would develop thrombotic events. And so it's now recommended that you target a hemoglobin no higher than 12. And if the hemoglobin goes above 12, you do not give EPO for chronic kidney disease or for any other condition for that matter because of adverse outcomes. So sticking with anemias, but shifting gears a little bit to megaloblastic anemias. So this basically means anemias related to an impairment in DNA synthesis. The hallmark conditions here are B12 and folate deficiency. So let's talk about that for a minute. So B12 deficiency, this is very likely you're going to encounter these scenarios in your clinic and on the board exam. The most common cause that we want to think about is pernicious anemia, which relates, it's an autoimmune condition where you have destruction of the parietal cells that produce intrinsic factor in the stomach, and that leads to decreased absorption of B12. Less often you can see B12 deficiency in the setting of malabsorption or malnutrition. So there's some associations here that you want to kind of have in your mind as you're going through a test question that you want to be able to recognize, oh, maybe they're trying to tell me about B12 deficiency. So association with other autoimmune diseases like Hashimoto's thyroiditis, premature graying of hair, or white forelock as it's known. If they give you a patient who's been on antacid suppression for a long time, like somebody with Zollinger-Ellison syndrome has been on pantoprazole or a proton pump inhibitor for years, and now they develop macrocytic anemia, think about B12 deficiency, because you need some gastric acid in order to release the B12 from your food. Patients that have reasons to think they have malabsorption, such as gastric bypass or pancreatic exocrine failure, like in chronic alcoholics with chronic pancreatitis, and those that have ileal disease. And then, of course, vegetarians may sometimes if they don't get adequate intake. So these are the associations to think about to kind of get you in the direction of B12 deficiency. You can sometimes see GI signs and symptoms, but the neurologic ones are the ones that we all remember and recall, right? So you can get a sensory neuropathy, you can get paresthesias, numbness of the extremities, and in more severe cases, dementia and personality changes. And sometimes patients can present with these changes without necessarily having the hematologic changes. Folate deficiency, on the other hand, while it can also cause a megaloblastic anemia, is not associated with any neurologic changes. You're going to look and think about folate deficiency in a pregnant woman where you have increased demands, hereditary hemolytic anemias where the red cell turnover increases the demands and the folate gets depleted. Certain drugs can lead to folate deficiency such as trimethoprim or Bactrim. And then in chronic alcoholics. Whether it's B12 or folate deficiency, you're going to have a very characteristic picture on your CBC and your blood smear. You're going to have an MCV greater than 100, and you're going to have hypersegmented polyneutrophils. That means more than 5 lobes in a neutrophil, and I'll show you a picture of that. That is the gold standard for diagnosing megaloblastic anemia. You actually have a little bit of hemolysis because these ineffective red cells are destroyed, but they're destroyed in the bone marrow. So this is a strange kind of hemolysis where your LDH is up, your bilirubin's up a little, your haptoglobin's down. But because it happens in your bone marrow before the cells get out into the circulation, your retic count is still low. So it's just a little bit of intramedullary or within the bone marrow hemolysis that can happen here. And you can actually develop pancytopenia, particularly with B12 deficiency. It doesn't just have to be the macrocytic anemia. And so this is a picture on the upper left of what a typical hypersegmented neutrophil, if you look at this one right here, where you have, right there, you have more than 5 lobes, and right there as well. And you can also appreciate that the size of these red cells is much larger. Remember, we talked about this is a lymphocyte as your control, and look at the size of these red cells. So macrocytic and hypersegmented. If you see a smear like that, even without clinical clues, you want to be thinking B12 folate deficiency. In diagnosing B12 deficiency, it's pretty straightforward. If your serum B12 level's below 200, you have B12 deficiency. But the one sort of twist here that you want to remember is that if you have a borderline B12 level, say between 200 and 400, and you have some suspicion, it still could be B12 deficiency, but you have to check the metabolites. And what you want to check here is the methylmalonic acid and homocysteine levels. Elevation of both of those will be diagnostic of a biochemical B12 deficiency, even if your serum B12 level is, say, 295. Once you've diagnosed B12 deficiency, look for the cause. Screen for pernicious anemia. And you do that by checking intrinsic factor antibodies. That is going to be the right answer if you're asked that on a test question, what's the next step after diagnosing B12 deficiency? About 30% of cases won't have the intrinsic factor antibody, and then you can screen for additional antibodies and serum gastrin levels as listed here. But if you have to remember one, remember intrinsic factor antibody, and remember the metabolites in cases where you're borderline. Folic acid is pretty straightforward. Diagnosing a deficiency state, you're going to have a low serum folate level. You don't have to worry about the metabolites as much. Make note of this table because it helps differentiate the findings in B12 and folate deficiency. With B12 deficiency, you're going to have a low serum level, and you're going to have elevation of both of your metabolites, and you're going to, in many cases, have a positive intrinsic factor. With folate deficiency, you're going to have a low folate level, and you'll only have an elevated homocysteine, but not MMA. And of course, intrinsic factor is not relevant because it's a different mechanism. Treatment's pretty straightforward. You replace B12 either parenteral with injections or high-dose oral therapy. If you diagnose pernicious anemia, you should start with injection therapy because there's an absorption problem. Folate replacement is usually given orally. And a point that's we may remember from way back in medical school, if you think there may be B12 deficiency and you treat only with folate, their neurologic symptoms are going to worsen, and that's a huge no-no. So if there's any suspicion, make sure you screen for B12 deficiency in addition to folate, and they're usually checked together. So we talked about sort of the microcytic anemias with iron deficiency, anemia of inflammation, the megaloblastic anemias. Let's talk about hemolytic anemia for a couple of minutes. So hemolytic anemia refers to premature destruction of red blood cells. And if you're not careful, it can be very easy to get confused in all the different kinds of hemolytic anemia. And so what we're going to do today is provide some structure and some mental organization of how we think about hemolytic anemias. First, when are we going to recognize it in a clinical case or in our clinic or in a question on an exam? What are the clues we look for? So we look for pallor, but you could see that with any kind of anemia. You look for jaundice and gallstones from the elevated indirect bilirubin. You look for splenomegaly. Your lab clues here, you're going to have a high LDH and a high reticulocyte count. This is a hyperproliferative anemia. You're going to have a low serum haptoglobin. And if and only if it's an autoimmune hemolytic anemia, you'll have a direct Coombs positive. On your smear, basically you're going to see signs of red cell fragmentation. So schistocytes, spur cells, bite cells, spherocytes, signs of shearing of red cells as they're going through the circulation will be your clue on your smear. So this is sort of the flavor, if you will, of a question that you're going to see and think, okay, this may be hemolysis. So let's say you're there and you think, I think this may be a hemolytic anemia question. So then how do we organize them in our mind? Basically, you can have two types of hemolytic anemia for the purposes of our discussion today. You can have an intrinsic hemolytic anemia, and that means the problem is within the red cell itself. And these are usually, with a few exceptions, usually hereditary. So you could have a problem inside the red blood cell, such as G6PD deficiency, which is an enzyme problem, or hemoglobinopathies, sickle cell thalassemias. Or it could be a red cell membrane problem, hereditary spherocytosis, and so on. So intrinsic problem in the red cell, usually hereditary. Or you could have an extrinsic hemolytic anemia. The problem is usually outside of the red cell in the environment, and these are usually acquired, not inherited. And the hallmark example here is autoimmune hemolytic anemia. And this is the one type of hemolysis where you'll have the positive Coombs test. Remember that. Okay, so if we have that framework, let's do a little bit of a deeper dive into some of these so that we're well prepared for any cases that may come along. So hemoglobinopathy, something's wrong with hemoglobin. It could be a qualitative problem like an amino acid substitution that you see in sickle cell, or it could be a quantitative problem where you're not making enough alpha or beta globin, as in alpha and beta thalassemias. And there's a few really high yield scenarios that you want to be familiar with. And that includes complications of sickle cell disease, recognizing what happens or what could happen with the spleen in hemoglobin SC disease, and understanding how some of the thalassemias can be misdiagnosed. So let's talk about that. Sickle cell disease, you can have different variations on the spectrum, right? So you can have sickle cell trait, which is hemoglobin AS. So you have one hemoglobin A, which is normal, and one hemoglobin S. Not of any true clinical significance. These people do pretty well. Their CBC looks essentially normal. True sickle cell disease homozygous is hemoglobin SS, and this is with the amino acid substitution that we talked about. And you can have varied expression and varied phenotypes, and we've all probably seen that in our clinic or in hospital rounds. But few points that I want you to remember about sickle cell SS disease. So these patients can have vaso-occlusive pain crises that lead to ER visits and hospitalizations, and those should be managed by ruling out infection and correcting dehydration and electrolyte abnormalities and giving supplemental oxygen and treating basically a painful sickle cell crisis. That sort of makes sense. There's nothing that complicated about that. But there's some other complications that are easier to write a test question on, and that includes an aplastic crisis that can happen related to parvovirus B19. So when should you think about this? So if you're given a patient with sickle cell disease who presents to the ER, to the hospital, and they have a painful crisis, and their hemoglobin is 6, and they're dehydrated, but they have a low retic count, an alarm should go off in your head. That's not expected. That's not normal. These patients usually have a high retic count, right? Hemolytic anemia. If you see a low retic count, think about aplastic crises. They're not making their red cells because of a parvovirus B19 infection. You'll never miss that question. These patients undergo functional asplenia due to autoinfarction of their spleen. Keep that in mind as we contrast with other hemoglobinopathies later. They are prone to complications like acute chest syndrome and strokes, and for some of these, and priapism, and for some of these, there may be indications for exchange red cell transfusions, avascular necrosis of the hip as well, as you see here. These patients are prone to folate deficiency. We talked about hemolytic anemias as a cause of folate deficiency, remember, so you should replace folate. On the outpatient non-acute setting, hydroxyurea is a useful therapy to increase fetal hemoglobin levels and thus decrease sickle hemoglobin levels. And because many of these patients require repeated red cell transfusions, they're prone to secondary iron overload, which can have dreaded complications in the liver and in the heart, and so iron chelation therapy is sometimes indicated for these cases. Hemoglobin SC disease is where you have one hemoglobin S and one hemoglobin C. It's intermediate in severity. It's not as bad as SS, but it's not as good as AS, which was trait. It's sort of in the middle. So the anemia tends to be milder. The pain crises tend to be less severe and less frequent. And these patients do not autoinfarct their spleen. They actually keep their spleen and it enlarges like it does in many hemolytic anemias. So what do you need to know here? There is a complication here called splenic sequestration. Because their spleen is enlarged, they can develop these crises where the red cells become trapped in their spleen. So when should you think about this? If you have a patient with sickle cell, and they might not tell you whether they have SC or SS, but they give you a patient with sickle cell who presents with what looks like a pain crisis and they have anemia, and they're really sick, and they have a tender left upper quadrant and an enlarged spleen, and maybe they're a little hypotensive. Think about splenic sequestration. The treatment is primarily supportive in the acute phase with IV fluid resuscitation, transfusion, and then later maybe a splenectomy once they've stabilized. So this happens only in SC disease because these are the ones that keep their spleen, meaning the spleen does not autoinfarct. As far as the thalassemias, so again, keeping ourselves organized, we're still in the hemolytic anemia section and the intrinsic disorders, right? Problem within the red cell itself. Thalassemias are inherited gene defects in either the alpha or beta globin gene, and these are quantitative issues, whereas sickle cell was qualitative. And so basically, for our purposes today, just know that you can have alpha thalassemia minor or beta thalassemia minor, and these patients are going to present with a mild anemia that's very microcytic, out of proportion. So the classic example here is you have a patient and the hemoglobin's 10.1, and the MCV is 59. And you're like, wow, that's really out of proportion. Think about thalassemias, right? The common scenario with these thalassemias are because somebody looks at their CBC quickly and sees microcytic anemia, puts them on iron. These patients are often misdiagnosed as having iron deficiency when they don't. And believe it or not, many of them have developed secondary iron overload or hemochromatosis because they were treated for years with iron by providers who aren't really paying attention and doing further workup. So this is a common misdiagnosis. So what are you going to see here on a test question? You'll be given a patient with a hemoglobin of 10 and an MCV of 59 and a ferritin of 300. So they're telling you it's not iron deficiency. And they're going to ask you, what should you do next? And the answer is not going to ever be to give iron. And the answer is going to be to check a hemoglobin electrophoresis. And when you check a hemoglobin electrophoresis, that's the one differentiating point between alpha and beta that I want you to know. With alpha thalassemia minor, your hemoglobin electrophoresis is normal. So this is actually kind of a diagnosis of exclusion. You can diagnose it with molecular testing, but nobody does that outside of the research setting. With beta thalassemia minor, you're going to have elevation of hemoglobin A2. So if you remember that one differentiating point between these two, you'll never miss a question or a case in your clinic regarding a microcytic anemia that's not iron deficiency. And these are just a couple of examples of smears of some of the things we see with these thalassemias. Howell-Joly bodies on the right, these are remnants of the red cell nucleus that are usually removed by a functioning spleen, and if you don't have a functioning spleen, then you see these in the circulation. And then target cells here, commonly seen in thalassemias, where you have this central sort of bullseye related to changes in the red cell membrane surface volume ratios. So think about hemolytic anemias and thalassemias when you see this. So that brings us to our next audience response question. A 17-year-old female, right upper quadrant pain for 2 weeks. A gallbladder ultrasound shows stones On her CBC, she got a little bit of anemia, hemoglobin 10.2, retic count is up at 5.7%. Basic chemistries are normal, and she's got a total bilirubin of 4.5, of which most of it's indirect. So, young female with this clinical picture. Which of the following is most likely associated lab finding? Spherocytes on the smear, high cholesterol, high triglycerides, teardrops on the smear, or smudge cells on the smear? What do you guys think? Fantastic. So 4/5 of you correctly recognize the common presentation of hereditary spherocytosis. So this is an intrinsic hemolytic anemia within the red cell membrane, and it renders the cells more susceptible to hemolysis. The clinical picture you want to think about here, because it's hereditary, look for a young person, maybe with a family history of anemia, history of enlarged spleen, gallstones. They might even give you in the history that they had to have a cholecystectomy for gallstones. And you're looking for spherocytes on the smear, chronic hemolysis with a high retic count, because that's what you should see with hemolysis. There are a couple of diagnostic tests, the osmotic fragility test and an EMA binding test that can be done to prove hereditary spherocytosis. And the treatment is largely supportive, but splenectomy can be done in severe cases. Main thing for all of you is recognizing the case or recognizing the typical patient. While we're on the red cell membrane problems, let's also say a word or two about G6PD deficiency. So whereas spherocytosis is a problem with a membrane, G6PD is a problem with an enzyme, and they're missing an enzyme, and it renders these red cells more susceptible to oxidative stress, right? So they develop attacks of hemolysis, and it can be in response to certain drugs or medications, as listed here, certain infections, DKA, certain dietary ingredients, including fava beans. And so you're going to have, and this is an X-linked disorder, and you're going to think about somebody from Mediterranean, European, or African descent here. And they're going to have these episodes of hemolysis that occur after certain stressors, like listed here. And you want to be able to recognize, to think about G6PD, and that I'd say the most testable point here is the issue of false negative tests in the acute setting. So all red cells in their early stages have good G6PD levels, and then when you have a deficiency, the levels wear off as the red cell ages. So if you test a G6PD enzyme level in the midst of an acute attack, it's going to look normal in everybody. But if you wait a couple of months, you'll pick up these patients that have the G6PD deficiency because you want to test the mature red cells, not the retics that are immediately coming up amidst an acute crisis. So be aware of the timing of testing for this to avoid false negatives, X-linked, certain ethnicities, recurrent hemolysis in response to stressors. And this is just a smear showing what spherocytes look like, where they lose their central pallor. So it's literally just like a red ball, a red sphere with no central pallor that we're used to seeing in our red cells. And these are microcytic because they are smaller than a neighboring lymphocyte, as you can see here. PNH is sort of one of those miscellaneous types of disorders. This is one of the very few that is a problem within the red cell, but it's not hereditary, it's acquired. And basically you have a defect in your membrane-bound proteins, and so you're sensitive to complement-mediated lysis. And so what I would want you to recall here is that these patients get hemolytic anemia, but they also are at risk for arterial and venous thrombosis, and that you diagnose with a special flow cytometry study looking at the two missing membrane proteins, CD55 and 59. So just store this somewhere in your mind that if you're ever given a case with hemolysis and they also have a PE or a DVT, think about PNH. As the name implies, they also may talk to you about having dark urine at night related to the hemolysis, but this is probably what may show up most likely if you're going to see that again. So that brings us to our next AR question. A 67-year-old female, rapid growing neck swelling, progressive fatigue, 15-pound weight loss, multiple rubbery lymph nodes on exam and an enlarged spleen. White count looks okay. Hemoglobin's 9.5, retic count's up a little bit. LDH is 884. It should be less than about 250. And indirect hyperbilirubinemia. Rest of her chemistry panels look fine. Which of the following is the most likely cause of the patient's anemia? Iron deficiency, B12 deficiency, inflammation, autoimmune hemolysis, or acute leukemia. What do you guys think? Pretty good. So 2/3 of you correctly guessed autoimmune hemolytic anemia. And this is a case where, just sort of a testing strategy point, use what you know, and sometimes that will be enough even if you don't know everything related to the question. So you could look at this question and say, I really don't know what the heck's going on with these lymph nodes and these, I really don't know. But you see that they're anemic, the retic count is up, the LDH is up, and the indirect bilirubin is up. Oh, that really looks like hemolysis. I know that. That looks like hemolysis. So if you use that and then you go through these answer choices, your eyes are gonna go right to D. Even if you don't know that this patient has a low-grade lymphoma that's associated with autoimmune hemolysis, which is what ultimately we were all hoping that you would, and many of you probably did. But even if you didn't get that, you can still get the answer right by using what you know to recognize hemolysis. So this is autoimmune hemolytic anemia. It's commonly associated with low-grade lymphomas and leukemias, which was as our case here. Know that there are some general hemolysis signs and symptoms. We've talked about them, the high LDH, the retic count being up. But this is the one that has the positive direct Coombs test because it's immune-mediated, okay? Know that there's two types. There's a warm antibody and a cold antibody, two types of warm autoimmune hemolysis. Warm antibody are typically IgG mediated and cold or IgM mediated. And this table will tell you everything that you need to know to distinguish between the two. So if you're smart and you're there and you diagnose this is autoimmune hemolysis, and then they ask you is it warm or cold, you won't get tripped up. So warm reacts at body temperature, cold is at room temperature. Warm is IgG, cold is IgM. These are clues you're going to pick up. The associations are kind of similar, although cold also can be with mycoplasma and Epstein-Barr. If I had to remember anything with cold, I'd remember that. You're going to have a positive Coombs in both, although slight variations on how they look. For warm antibody, they respond well to steroids. With cold, they don't. And so with cold antibody, we just kind of try to keep the patient warm. Warm them up, they'll stop hemolyzing. And in refractory cases, we can use Rituxan. So differentiating the two types of autoimmune hemolysis, if you know this, you know a lot. A word about hemochromatosis and then before we move on to clotting and bleeding. So this is a hereditary condition, autosomal recessive, where you have a problem with iron overload. And basically it's a mutation in the HFE gene that leads, and so you have a defective sensor in your gut, and you're absorbing way too much iron from your diet as opposed to what you should be because that sensor is off. In the short term, it may not mean anything, but over the years and decades, it leads to an accumulation of iron, and it can lead to all these problems that you see here. Endocrinopathies like diabetes, arthropathies, liver disease, including cirrhosis, cardiomyopathy and conduction defects, susceptibility to certain infections, right? You want to distinguish it from secondary iron overload. If it's secondary, you're going to have a clue in the history, like they have a sickle cell disease and they get transfusions all the time, or they have alpha thalassemia trait, remember? And somebody has been giving them oral iron erroneously for 20 years. You're going to get those kind of clues if it's secondary. Women may present later in life than men because they have an treatment with menstruation, right? So they may not show iron overload until later in life. It used to be that to pick this up in a case or in your clinic, you would look for the bronzing of the skin and the diabetes and liver cirrhosis. But truth be told, nowadays everybody gets lab work all the time. It very rarely gets to that point before it's diagnosed. So if you're going to see this, and every time I've seen this on a board type question, it's going to be a patient with very subtle and non-specific symptoms. Some fatigue, maybe a little bit of erectile dysfunction, some arthralgias, right? You're going to see those kind of symptoms, and then they're going to ask you, what might you do next? And you're going to want to think about hemochromatosis, especially if they give you like, oh, recently diagnosed with diabetes or something like that. But the symptoms can be very nonspecific. The screening test of choice is the iron saturation. The ferritin level will also be elevated, and then to confirm the diagnosis, you do peripheral blood genetic testing for C282Y and H63D. These are the HFE gene mutations. The treatment is phlebotomy to remove the excessive iron, and your target is to bring your ferritin levels down to less than 50 to 100, reduces the risk of long-term organ damage if you can do that. Very good. So that was some discussion primarily focused on red cell disorders. Now let's tackle bleeding and clotting. And again, my focus is trying to simplify this so that you're prepared for the practical components of this. So general approach to bleeding, right? If they give you a patient who's bleeding, where do you even begin? Let's organize it. First, understand that there are two steps to hemostasis. You have primary hemostasis, which is a platelet-driven issue. So when you have injury to tissue or a vessel, the first 12 to 24 hours, primary hemostasis, platelet plug formation. Okay, so you have platelet adhesion and platelet aggregation, but what you need to remember is it's a platelet-driven issue. Then, to sort of bring it home afterwards, secondary hemostasis, that is driven by the coagulation cascade. All the clotting factors, factor 7 and 8 and 9 and 10, that's secondary hemostasis, which happens after the platelet plug is formed in the first 12 to 24 hours. So why does this matter to you? It matters because these patients, depending on where their problem is, are going to look different to you. So people that have a problem with primary hemostasis, it's a platelet-driven issue, those patients will typically have superficial mucocutaneous bleeding, milder bleeding. So this is going to be somebody with menorrhagia, epistaxis, maybe some petechiae, maybe bleeding in their gums when they brush their teeth. This is very typical of platelet problem bleeding, primary hemostatic defect. If the problem's in the secondary hemostatic pathway, the bleeding's more severe. And this is deeper, soft tissue bleeding, hemarthroses in the joints. Think about a hemophiliac patient, right? So the bleeding's going to be more impressive, it's going to be more significant, it's going to be deeper. So these patients will look different. And even if you just know that, you're automatically going to be able to eliminate 2 or 3 answer choices if you know which disorders are primary and secondary. So very important to know what these patients look like. Regardless, if you have a bleeding patient, you start the workup with basic coags, PT, PTT, platelet count, and then in some cases, platelet function testing. So what we're going to do now is dive into this a little deeper, and I'm going to start with primary hemostasis, right? So platelet problems. So you can have 2 kinds of platelet problems, basically. Either you don't have enough of them, thrombocytopenia, or they don't work well, qualitative platelet problems. So let's talk about thrombocytopenias first. So you could become thrombocytopenic from not making enough platelets, from having platelets sequestered, like in your spleen, or from increased destruction of platelets peripherally. The first 2 I'm going to spend maybe 30 seconds on because they're not as exciting and they're not as testable. And they kind of make a lot of sense. You don't need me to explain it. Decreased production. Yeah, so you have a bone marrow problem. Deficiency of a vitamin, you have a virus that's suppressing your bone marrow, or a drug that's suppressing your bone marrow, low platelets, it makes sense, right? Sequestration, if you have a big spleen, such as somebody who's a cirrhotic, your platelets get trapped in there. These cirrhotics often have platelet counts 60, 80,000, that's where they live. Okay, it is what it is. Where I want to spend the time, though, is on increased destruction of platelets, because this is the exciting stuff for test question writers. And this is the stuff that, if you're doing rounds in the hospital, is of most immediate threat to your patients as well. So ITP, TTP, DIC, and HIT. So let's make sure that you're very comfortable, if you're given a low platelet count, to know which of these they're expecting you to select. So ITP, immune thrombocytopenic purpura. In children, it can be a transient disease following a virus, but in adults, it's usually a chronic disease. In many cases, it's idiopathic, but there can be certain drugs. It can be seen in certain lymphomas or in viruses. And they're going to have the typical platelet bleeding that we talked about, right? Easy bruising, petechiae, mucosal bleeding. Significant or deep tissue bleeding is rare. This is IgG antibody mediated. However, don't order the antibody test. It's not sensitive or specific enough. So this is, in fact, a clinical diagnosis. So the answer to diagnose ITP is never going to be to order a specific blood test, because there isn't one. The treatment, if the platelets are above 30, is nothing. You just watch them. And if platelets drop below 30, or if they're bleeding, first-line therapy is usually steroids. If they have severe thrombocytopenia or bleeding, you can give IVIG. And in refractory cases, there's rituximab, there's platelet growth factors. But if you remember steroids, you'll be in good shape. High-dose prednisone, for example. So what is this patient going to look like? So you're going to see a patient who's reasonably healthy, comes in, platelet count of 25,000, maybe a little bit of mucosal bleeding, and nothing else is wrong with them. Their white count looks great, their hemoglobin looks great, their coags look great, they're not sick. Think about ITP. It's just, even though it doesn't stand for isolated, you can think of it as isolated thrombocytopenia, and you'll help you remember it. It's just a platelet problem. These people don't look sick. Conversely, we have TTP and its related sister microangiopathies, atypical HUS, typical HUS, and HELP syndrome. So with TTP, we all may remember the pentad, but the two most important ones are the thrombocytopenia and the microangiopathic hemolytic anemia. You may also see fever, renal dysfunction, and central nervous system changes. On your peripheral smear, you're going to see schistocytes. Remember that for TTP. If you see schistocytes, think about TTP. They're going to be thrombocytopenic. Their white count will be fine. And they're going to also have normal coags. Okay? So you're already seeing why this looks different from ITP, because I told you in ITP it was just a platelet problem. Here they're going to be anemic, and they're going to have schistocytes on their smear. Okay? And all the abnormal hemolysis labs. What does a schistocyte look like? This right here. It looks like literally a red cell got sliced in half as it was going through your circulation. There's one here, there's one here. If you see these, you're going to be expected to recognize those as schistocytes, and in the right context, thinking about TTP. We've learned a lot in the last decade about the pathophys of TTP. So it all relates to this enzyme called ADAMTS13. And this enzyme, this is responsible for breaking down large multimers of von Willebrand factor. So when you have a deficiency of this enzyme, that's what leads to TTP, because these large von Willebrand multimers are not broken down, and they clump together, and they plug up the microcirculation and lead to all these problems. So TTP is caused by a deficiency of this enzyme, ADAMTS13. How can you become deficient in this enzyme? Well, rarely it can be a hereditary defect, but more commonly it's an acquired defect, and that's through an antibody that inhibits the ADAMTS13 from functioning and thus leads to TTP. And this can be seen in cases related to certain medications, autoimmune diseases, pregnancy postpartum, and in oncology patients after stem cell transplants or with advanced malignancy. So think about these as possible clues for, in a question stem for somebody who may present with TTP. A young woman, 1 week postpartum, for example, who presents with anemia and thrombocytopenia and schistocytes, this could be another clue to help you. Acquired ADAMTS13 is the pathophysiology. TTP is considered a medical emergency, and that's because if you don't recognize and treat it, these patients are going to die, probably within 48 to 72 hours. So early diagnosis and recognition and treatment is the key. There are assays to check this ADAMTS13, but they take a week to come back. So you can't use that to guide your management. You have to make a clinical diagnosis and initiate therapy. And that therapy for most cases of TTP is plasma exchange or plasmapheresis. And what you're doing here is removing that bad antibody that's binding to the ADAMTS13. You're removing that and replacing it with good plasma that has the enzyme. We knew forever that plasma exchange was the treatment, but only recently do we understand why and how, and it relates to this enzyme. There are a few exceptions where plasma exchange does not work, and that's basically in anything cancer-related. So if you have a patient who got TTP after chemo or TTP after transplant, it's supportive care. Unfortunately, plasma exchange doesn't work as well there. Never give platelet transfusions to a patient with TTP. It's going to add fuel to the fire, as they say. So if they show you a patient whose bleeding platelet count is 9, but the rest of the question looks like TTP, never pick platelet transfusions. There are some of the sister disorders, as I mentioned, that have the same general concept, but slight variations. So we all may remember hemolytic uremic syndrome, the E. coli 0157H7, that's the middle one here. You'll see a patient who had diarrhea, and then after that, they tank, and they have these kinds of problems. Treatment here is supportive. Atypical HUS, similar TTP, but more renal involvement. But the key here is that the pathophysiology is different, and here it is not an ADAMTS13 issue. It relates to complement dysregulation. And so actually the treatment here is a monoclonal antibody against complement called eculizumab. That's actually the treatment of choice here, so it's very different. So you want to keep that in mind with atypical HUS. And then there's HELP syndrome there. It's going to be in a woman with pregnancy or in the immediate postpartum who has a history of eclampsia, and you see hemolysis, elevated liver enzymes, and low platelets. So these are kind of all the diseases in the differential, but TTP is the one that you're most likely to see. And how about DIC? So All of us who've rotated through the ICU or rounded in the ICU are probably pretty familiar with this. You have widespread activation of the clotting cascade related to some sort of underlying bad illness, whether it's an OB catastrophe, cancer, malignancy. And you're going to see a lot of the same lab abnormalities with the elevated schistocytes, the low platelet counts, the anemia. The difference here is your coags are abnormal too. So you're going to have abnormal PT and PTT. And that's going to be your simplest way to differentiate DIC from TTP, the coags. If your coags are normal and you've got schistocytes and low platelets, but the coags are normal, it's TTP. If the PT and PTT are abnormal, think about DIC. So again, even if you don't quite understand everything that's going on in the question, if you remember some of these things, you'll easily cross things off of your answer choices and get the problem right. The treatment for DIC is just supportive. You treat the underlying disorder and you give blood products. So cryoprecipitate is useful when your fibrinogen is low. You replace that with cryo. FFP is useful to correct your prolonged PT and PTT times, and then platelet and red cell transfusions are pretty self-explanatory. So that brings us to our next AR question. A dialysis patient on heparin develops thrombocytopenia. Platelet drops from 220 to 60. Associated with right calf and leg pain and swelling, and you diagnose a DVT of the right leg. What are you going to do next? Stop heparin and prescribe bivalirudin, change heparin to low molecular weight heparin, stop heparin and prescribe argatroban, recommend plasma exchange transfusion, or stop heparin and start aspirin for prophylaxis. What do you guys think? Fantastic. So 3/4 you recognize that the management of HIT involves stopping heparin and prescribing something that has absolutely no relation to heparin, okay? So low molecular weight heparin would not be appropriate. So then it's down to argatroban or bivalirudin, and here the knowledge point is understanding that bivalirudin is not used in kidney disease, and so argatroban would be the drug of choice in somebody with underlying renal disease. We would not do plasma exchange because we don't think this is TTP, right? And aspirin would be insufficient for prophylaxis. So heparin-induced thrombocytopenia. There's a HIT type 1, which is non-immune and of no clinical consequence. Your platelets drop a day or two after starting heparin and they come back up. HIT type 2 is the immune-mediated, and this is the one related to antibody complexes with heparin and platelet factor 4. And so typically after 5 to 8 days of exposure to a heparin product, platelets will start to drop, and these patients become hypercoagulable. So even though platelets are low, they paradoxically clot, not bleed. Highest risk is with unfractionated heparin, but you can see it with low molecular weight heparin. And there is cross-reactivity, so you never switch as a treatment. These clots can be arterial or venous. And so if you recognize possible HIT, your very first step is to stop any and all heparins, including flushes, low molecular weight heparins, subcutaneous heparins, stop any and all heparins. But that's not enough because these patients, as I said, remain hypercoagulable related to these circulating complexes for many weeks, if not several months. And therefore, you must start alternative anticoagulation as well. To diagnose, the gold standard is the HIT antibody panel and the serotonin release assay as a confirmation. But these studies can take a few days, and so it's really a clinical diagnosis until you get the confirmation. We talked about stopping heparins, and because these patients are still at risk for clot, you start an alternative anticoagulation. And these are the choices that you see here, argatroban, and then some newer drugs that have now been studied in HIT, including fondaparinux and some of the new direct oral anticoagulants. Even if they don't have clots, you still anticoagulate them for at least 3 months. If you're going to switch to warfarin, you only do so after the platelets have recovered above 100. And you also never give platelet transfusions here with HIT. You're going to add fuel to the fire. So recognize HIT, and recognizing it's not going to be that difficult, I think, because you're going to get somebody who's post-hip fracture repair in the hospital on heparin, day number 8, their platelets drop. You're going to get that. You're going to know it's HIT, but knowing how to manage it and what drugs to use and not use is going to be your key to doing well with this. So all of that discussion that we had related to primary hemostasis, right? platelet problems, quantitative. Well, what about qualitative, where it's still a platelet problem, but now it's not a number issue, they don't work well? That's what von Willebrand's disease is. And so that is also going to look like that patient with the mucocutaneous bleeding, but this is an inherited bleeding disorder. There are several types, not critical that you know that. It's autosomal dominant, and you're going to look for a younger patient who has a history of menorrhagia, bleeding after tooth extractions, maybe some nose bleeding, and in some cases, they may actually have a prolonged PTT because von Willebrand is, in addition to being responsible for sticking platelets together, it's also a carrier for factor VIII. And so if you remember that function, you'll understand why the PTT can be affected a little bit as well. So this is hereditary younger patient with bleeding from maybe teenage years, including menorrhagia. There's a battery of screening tests looking at the von Willebrand antigen and activity level, and then some confirmatory tests. The treatment is very specialized. If you're going to know one thing about treatment, know desmopressin or DDAVP. This is a medication that increases the release of von Willebrand factor from endothelial cells. And so we use this for many types of von Willebrand to help with bleeding. But I think main thing for here is going to be recognizing what it looks like. And so again, if you recall that this is within the primary hemostatic pathway, then if you're given a test question where they have somebody with big bleeds into their joints, you know that's never going to be von Willebrand's, and you'll cross that off your list and you'll never get that wrong, right? So organizing it in your mind is going to go a long way, even if you don't know exactly what's going on in the case. Okay, so that concludes primary hemostasis. Now, for us to talk about secondary hemostasis, and remember, this is like the heavy hammer that comes in after the first 12 to 24 hours, and this is all the clotting factors and everybody's favorite graphic from medical school, the coagulation cascade, right? So let's simplify this for you as well. And understanding just a very few simple facts about this graph will lead you a long way in the next 5 to 10 minutes. So at the site of tissue injury or vessel injury, when you first have a problem, the very first thing that happens is that tissue factor is released that interacts with factor 7A, okay? And factor 7A activates factor 10 to factor 10A, and then factor 10A activates prothrombin to thrombin. Thrombin is really the key here, and it's how do you get to activate thrombin. So that's how this all starts, and this is known as the extrinsic pathway of coagulation. And this extrinsic pathway is measured by the PT, or the prothrombin time. This is the first step whenever you have tissue injury, okay? Now, unfortunately, the thrombin that's developed, and I told you that thrombin's the key, right? Because as you can see, thrombin then converts fibrinogen to fibrin, and that converts to your clot, and that creates your whole endgame. Thrombin's the key. But unfortunately, the extrinsic pathway alone, it only produces a very small amount of this thrombin. So then what happens is this small amount of thrombin activates the intrinsic pathway, which then amplifies exponentially the amount of thrombin that's produced. So it kicks it into high gear to make more thrombin. And this is by activating factor 12 to 11 to 9 to 8. This is known as the intrinsic pathway that comes in bringing up the rear, and this is measured by the PTT, okay? So if you kind of think about that and you look at who are the key players here, 12, 11, 9, and 8, PTT, intrinsic, versus the extrinsic, who are the key players here, 7. Everything I tell you after this is just going to kind of make sense, and it's just going to flow, and you're not going to memorize anything because you're just going to recall it and go back and reference this and say, oh yeah, that makes sense why that would be like that. Regardless of where your problem is in the secondary hemostasis, chances are you're going to have a clue with a prolongation of a PT or a PTT here, okay? And I want you to be comfortable with understanding how do you proceed in working that up. So if you're given a case, somebody's bleeding, and it's deeper soft tissue bleeding, and you're like, yes, this is secondary hemostasis, clotting factor problem, and you look and the PTT is 55, right? It's supposed to be less than 35, let's say. It's 55. You say, okay, great. Now what do I do? You do a mixing study. And let me explain how mixing studies work. Basically, mixing studies are done for the goal is to determine if your factor problem is related to a deficiency of that factor, such as somebody with hemophilia who doesn't have any factor VIII, or is it related to an inhibitor that is neutralizing your clotting factor? And there are examples of factor inhibitors as well. Mixing study is going to tell you that. Is it a deficiency problem or an inhibitor problem? And that's going to, like an algorithm, drop you right into the bucket of your diagnosis. So let's go through the scenarios. If your problem is a factor deficiency, like a hemophiliac, let's look at the top here. You have your patient plasma. They have no clotting factor in it because they're a hemophiliac. They just don't have any. You mix it 1-to-1 with normal control plasma, and you incubate it for a couple of hours, and the clotting times are going to correct. That PTT is going to go from 55 down to 35. Why? Because the clotting factor in the control plasma took over and did the job. So your PTT corrects to normal, it's a deficiency. On the other hand, if your problem is an inhibitor, then here's your patient plasma, and you can see you have clotting factor, but it's being neutralized by these antibodies, and you mix it with normal plasma, and you incubate it for a couple of hours. Well, guess what's going to happen? That PTT is still going to be 55 because the antibody in the patient plasma is just going to neutralize all the new clotting factor as well. So the clotting times do not correct. It means there's an inhibitor. So that's what the mixing study will help you determine. So continuing on this example with PTT, let's say that the clotting times did correct. So it's a deficiency. We talked about hemophilia as the most common cause you should know about. If it does not correct, you have an inhibitor. There's two types of inhibitors that I want you to know about. One is these factor VIII inhibitors. These are acquired, older patients, sometimes younger women postpartum, and they lead to deep soft tissue, life-threatening bleeds. Can also be in patients with lupus or rheumatoid arthritis, some sort of an underlying illness or problem. They get acquired factor VIII inhibitors. Think about that in a patient with deep bleeding and a mixing study that does not correct. On the flip side, if you have a mixing study that does not correct, it could also be related to antiphospholipid antibodies. But the twist here is these patients don't bleed, they clot. So stay with me here. If you have a prolonged PTT, and you're very proud of yourself because you remembered how to go through the mixing study and it didn't correct, and you're like, yes, this is an inhibitor. But instead of bleeding, the patient has DVTs, think of antiphospholipid antibody syndrome. And your answer is right there for you. It drops you into the right bucket automatically if you just think through it structurally. Okay, so this chart summarizes a lot of what I've just gone over with you. What I would highlight here is row number 2. So what scenario and what do you think about? If you have an elevated PT, but your PTT is normal, think of a factor VII deficiency, extrinsic pathway, remember? Extrinsic pathway. And here you're going to be thinking about vitamin K deficiency, warfarin, liver disease. These are the common scenarios for that. On the flip side, if you have an elevated PTT, but a normal PT, well, then this is basically everything that I just went over with you. You do a mixing study. If it corrects, you think about a deficiency. If it doesn't, you think about an inhibitor. This is what we just went over. And then there's a couple of wild cards that you should know just because it's very easy to write a test question on them. One is a patient that has an elevated PTT alone, but they don't bleed at all or clot. They don't do anything. They're just fine. Think about a factor 12 deficiency. And then you may have a patient where both PT and PTT are normal, but they do bleed. I think, think factor 13 deficiency. These are two oddballs. We don't see them very often in practice, but again, they lend themselves well because they're oddballs to writing questions about them. And then a reminder here that if your PT and PTT are normal, also can think about platelet problems. And this just summarizes some of what we went over, a little bit of detail about hemophilia. And then, so with hemophilia here, this is going to be prolonged PTT, and the mixing study does correct. With vitamin K deficiency, as you recall, this is going to be a prolonged PT, right? Because it's extrinsic pathway. And as we talked about, think about liver disease and warfarin, and then sometimes people that have been on prolonged antibiotics or TPN. Okay, which of the following disorders may present with a normal PT and normal PTT, but evidence of bleeding with a prolonged bleeding time? What do you guys think? Fantastic. So this is what von Willebrand's disease looked like. Bleeding time is a measure of platelet function. You recognize that if the PT and PTT are normal, it can't be factor 8, it can't be factor 12, it could be factor 13, right? But not 12. So that's great. So you guys got that. Another question. A 36-year-old postpartum woman returns 48 hours after birth complaining of abdominal pain and epistaxis. She had a normal pregnancy and delivery. Exam is benign except for fresh blood in the posterior oropharynx. Her labs at discharge were normal, and now 2 days later, she has a hemoglobin of 8, a platelet count of 4, PT and PTT are normal, fibrinogen's 350, LDH is 12,000. Creatinine's up at 3.5, retic count is up, and indirect bilirubin is up at 4.5. 48 hours postpartum, all the wheels fell off. What's going on here? Which of the following is the most appropriate next step in management? Platelet transfusion, heparin infusion, platelets and FFP, bone marrow biopsy, or therapeutic plasma exchange? Yeah, that's awesome. This is exactly what TTP looks like. You guys got it. That's great. So we spent some time talking about bleeding. I'm going to spend less time talking about clotting because I think this is not as conceptually difficult. But let's hit on a few things. So hereditary and acquired thrombophilias, right? So this is switching gears totally from a bleeding patient to a clotting patient. They're the ones that we check for in our thrombophilia panels: the factor V Leiden, prothrombin gene, protein C and S, antithrombin. You should be familiar with them. Those are the ones that we look for. But there's also a lot of acquired causes of thrombosis that you can see listed here that I won't go over in the interest of time. But what you should know is that when should you test for thrombophilia? Somebody who clots at a young age, somebody who has recurrent clots, somebody with a strong family history of clotting, or somebody that has clots in a really unusual spot, like a splanchnic vein thrombosis, Budd-Chiari syndrome, these strange, things that should raise your red flag a little bit that something's going on. And then there's the panel of tests that you look for. We talked a little bit about antiphospholipid antibody syndrome a few minutes ago. This is just a little bit more detail on it. Again, this is the prolonged PTT. The mixing study does not correct, so you have an inhibitor, but they clot instead of bleed. That's why it's in this section. And they also may have pregnancy morbidity. There's 3 ways you can test for this with lupus anticoagulant, cardiolipin antibody, and beta-2 glycoprotein-1 antibodies. So you have a pregnant patient, 28 weeks gestation, DVT left leg. What do? Refer to OB, unfractionated heparin, low molecular weight heparin, rivaroxaban, or warfarin. Yeah, so more than half of you correctly answered low molecular weight heparin. So we'll spend just a minute. I think you're all familiar with the various anticoagulants that are out there, but really I think the highest yield part is knowing which situations you prefer which drugs or which classes. And so that's what we'll spend just a minute on. So this is some info on the basic classes that we have: vitamin K antagonists, the heparins, the factor Xa inhibitors, and the direct thrombin inhibitors, including some of the new oral anticoagulants, the rivaroxaban, apixaban, and then dabigatran down at the bottom, and some of the things, the conditions that they're indicated for. But I want to hit on a couple of key scenarios that I see over and over again and that you may see so that you're good with them. Initial management of DVT, PE, low molecular weight heparin is a great drug. You might consider IV unfractionated heparin in somebody who's got a massive PE, somebody who might require surgery, or somebody who has renal failure. You should remember that thrombolytic therapy like TPA can be considered in a patient with a really massive PE where they have hemodynamic compromise and right heart strain. And so when you've got a patient with PE and they're going downhill fast, think about thrombolytic therapy. That's going to be your best answer. We talked about HIT and which of the non-heparin drugs are preferred there. In pregnancy, as the question went over, low molecular weight heparin is basically it. The DOACs, or the direct oral anticoagulants, no good in pregnancy. Warfarin, no good in pregnancy, so think of low molecular weight heparin. In malignancy, it's also long been favored low molecular weight heparin. That's evolving. We're getting some data on some of the DOACs now, but for your purposes, think low molecular weight heparin. Renal disease, you want to avoid the low molecular weight heparin. As far as duration of therapy, some controversy, but this is what you should know. If you have a provoked DVT or PE with a transient risk factor, like after hip surgery, 3 months is all you need. If it's unprovoked, you don't know what caused it, minimum 3 months, but you can consider long-term. And if you have recurrent VTE, then it's indefinite. This is per chest guidelines from American College of Chest Physicians. So when do you think about an IVC filter? This is another thing I see come up. If you either can't anticoagulate or you tried to anticoagulate but it didn't work, or they have such bad cardiopulmonary compromise that if they showered any more clots, it would be fatal, or sometimes in prophylaxis for like bariatric surgery. There's a slide or two here on transfusions. I think what I want to focus on here is just transfusion reactions for just a minute. Recall that there are a few different kinds of transfusion reactions. Acute hemolytic is the really bad one. It relates to ABO incompatibility, usually from clerical error, and these patients have fever and evidence of hemolysis at some point during their transfusion. You have to stop the blood immediately, notify blood bank, and start supportive measures and hydration. Delayed hemolytic reaction usually happens like a week later. So they get their transfusion, they do fine, and they come back a week later, they've got some dark urine, a little low-grade fever, and their hemoglobin dropped again. Think of a delayed hemolytic reaction. These are usually RH incompatibility. And then you can have the febrile reactions, which are not hemolytic. These are the most common ones we see in patient. Patient has a low-grade fever while they're getting a transfusion, but there's no hemolysis. It's related to leukocytes and the cytokines in the transfused blood product. Very good. So in the final third or so of the hematology talk, I want to hit some high points on bone marrow disorders and hematologic cancers. And again, my goal here is having you recognize the types of cases and differentiating one from another. So bone marrow disease, aplastic anemia. These are patients that are going to present with pancytopenia. Even though the name just says anemia, it's all lineages involved. Pancytopenia, it's a stem cell disorder. Nobody knows what causes it in most cases. In some cases, it can be a virus or a drug. Something happens and they stop making their cells in their bone marrow. It's often in young patients, and their symptoms will depend on what counts are most low. So it might be infection, it might be bleeding. Their bone marrow is hypocellular. They don't have cells in their bone marrow. It's like there's nothing there. They have no precursor cells. It's hypocellular. Remember that, because we're going to differentiate that with others down the road. So no cells in the bone marrow. In younger patients, we treat with a bone marrow transplant. In older patients, we use immunosuppression. But here, I think what you should most be versed with is recognizing the diagnosis. So often a young patient, out of the blue, pancytopenia, no cells in their bone marrow. So let's talk about this 73-year-old man, history of diabetes and hypertension, who presents to the ED with fatigue, headache, and nosebleeds for a week. On exam, no fever, but he's pale, some petechiae, medial deviation of the left eye. Otherwise, exam is unremarkable. He's pancytopenic and pretty severely so. Platelet count of only 12. Peripheral smear shows blasts without hour rods. Bone marrow shows a hypercellular marrow with 68% blasts, and they're positive for these markers, including CD19 and 20. CT of chest, abdomen, and pelvis shows mild diffuse lymphadenopathy and splenomegaly. What is the most likely diagnosis? Large granular lymphocyte leukemia, acute myeloid leukemia, CLL, CML, or ALL. What do you guys think? Okay, so kind of all over the place. And that's fine, that's good. This is why we're here, right? So I'm going to make this very easy for you over the next 5 to 10 minutes, or at least I hope I am. So the correct answer here is ALL. So about a third of you got that right. And I'm going to show you how you would pick that up going forward. So heme cancers, you want to be able to recognize and differentiate all these different ones listed here. And again, our goal is to simplify this by hitting the high points. And so let's go. Acute leukemias. Blasts, immature cells. The cells, they lose their ability to differentiate, but they retain their ability to replicate. So they keep replicating and multiplying, but they're not differentiating. They remain immature. That's what blasts are. They're going to present just like this patient did in the case.
severe pancytopenia, blasts in the blood smear, blasts in the bone marrow. Their symptoms are related to the low count, so infections, fatigue, bleeding. You work up acute leukemias with bone marrow studies, specialized cytogenetics. The treatment's very complex and more than probably what you need to concern yourself with right now, other than knowing that it's complicated and there's a few different phases to it. This is what blasts look like on the smear if you're shown it. So here the white blood cell is 2 or 3 times, probably 3 times larger than the neighboring red cell. Large nucleus, prominent nucleoli, and then a thin rim of pale blue cytoplasm around it. That's typical for a blast, as you see here. So they're much larger. Here again, you can see a blast, much bigger cell than the red cells around it. These little splinter things here, these are called Auer rods. These are blue or azurophilic needle-shaped crystals. You see them in AML, and only in AML. And if you are shown a blast with this rod in it, it's AML. And that's easy, and you take the question and you run. So remember that. So AML, we talked about Auer rods. AML can arise, this is acute myelogenous leukemia. AML can arise after toxin exposure like benzene. It can arise from preceding bone marrow diseases like myelodysplasia. But the bottom line is these patients are sick, they're pancytopenic, they have a lot of blasts, and sometimes if you have too many blasts, you can develop hyperviscosity syndrome, where these blasts plug up the microcirculation and you develop CNS and pulmonary problems, and you need to get emergency leukapheresis to have these white cells removed. Recall that, and I've seen a question where they give you a acute leukemic white count's 800, and they say 45% blasts, and they're confused, and they're hypoxic. What's the next best first step? It's not bone marrow biopsy, it's not chemo, it's refer for leukapheresis urgently because that patient has hyperviscosity syndrome. That is fair game for you to recognize and manage that. Cytogenetics are very important, and then there's one special subtype of AML that is unique and thus easy to write test questions on, and that's APL, or acute promyelocytic leukemia. And this slide will tell you whatever you need to know about that. There's a specific translocation here. It's the 1517 translocation. It relates to the retinoic acid receptor gene. This subset of leukemias is actually treated with a vitamin, ATRA, all-trans retinoic acid, which can put many of these patients in remission. There's a complication of ATRA therapy called differentiation syndrome, where they get very sick with volume overload, respiratory distress, hypotension, and that's treated with high-dose steroids. So if they give you a patient with this type of AML and they get sick after ATRA, no differentiation syndrome. And also know that this is the one subtype of AML that can present with DIC. So if they give you an AML patient, blasts, Auer rods, and you get excited, and you're like, yes, I know this is AML, and then they ask you what subtype of AML is, and you're like, are you kidding me? How am I going to know M2 or M3 or M4? If they tell you that the fibrinogen's low and they're bleeding from every orifice, you're expected to know, oh, this is the only one that has DIC. You won't miss this. AML M3, which is the promyelocytic leukemia. ALL, acute lymphoblastic leukemia, similar in many regards, pancytopenia, blasts, they're sick, right? So let's just focus on what's different, because on a smear, unless you get that Auer rod, you're not going to be able to tell whether that blast is AML or ALL, but you know it's one of them, right? So with ALL, your clues are that this is the acute leukemia that can present with lymphadenopathy, hepatosplenomegaly, and CNS involvement. It's the only one. So for your purposes, ALL has CNS involvement, AML does not. Okay? So the typical ALL patient is going to be just like the one in our case. They had a cranial nerve palsy, right? They had a cranial nerve palsy. They had, I think, an enlarged spleen, may or may not have some lymphadenopathy. It kind of looks a little like lymphoma, but they've got a lot of blasts. ALL is going to be your diagnosis. And if you know that, you're good to go with that. Myelodysplastic syndrome. This used to be called pre-leukemia. This is a disorder of the bone marrow with ineffective blood cell production. These patients will present with often pancytopenia, and it's a problem where the cells are there, but they cannot mature properly. They're dysplastic. Their morphology is abnormal. These patients, as I said, may progress to acute leukemia. The bone marrow here is going to be hypercellular. A lot of cells in your bone marrow, but they're just not effectively being matured and sent out to do their job. And with myelodysplastic syndrome, the management is primarily supportive, but we do have some chemotherapy drugs that prolong survival now, these hypomethylating agents. Young patients can get transplanted. And as is often the case, if there's one variant of the syndrome that's different, you should know it. And in this case, it's the 5q deletion syndrome of MDS. And this is younger patients, more favorable prognosis, and they typically present with high platelet counts, and they respond to lenalidomide therapy. So it's just, again, a little bit of a quirky variant, but if you get that, you'll get a question right that maybe others may not, the 5q deletion syndrome. So MDS, hypercellular marrow, pancytopenia, risk of progression to leukemia. This is typically going to be an older patient, 70s, 80s, 90s, who presents with pancytopenia. No blasts here. So if you're given pancytopenia with blasts, then you're like, okay, AML or ALL, right? And then I got to remember how that's different. But if you're given pancytopenia and no blasts, older patient, think about MDS, especially if they give you some dysplastic features. Next question, a 32-year-old female develops a large spontaneous hematoma under her tongue and in her thigh. She's otherwise healthy. She's got a big spleen, and her white count's 110 with a little bit of everything. Some segs, some bands, some lymphs, some myelocytes, metamyelocytes, a few blasts, but not like ALL, AML type numbers, just a few. I'm giving you some clues here. A little bit of eosinophils and some basophils. Hemoglobin's 10, platelets are high at 898, and her coags are normal. Which of the following is the most appropriate next step in management? Review the smear and look for the 922 chromosome translocation. CT her abdomen, FNA of that big spleen, look for the JAK mutation, or check von Willebrand panel. What do you guys think? Okay, so you guys knew that we had to check for some kind of a mutation. The correct answer is the 922. This is CML, and this is what CML looks like. And so let's go over that a little bit. So the myeloproliferative neoplasm. So myelo is cells, proliferative is too many. This is production of too many cells. And there are 4 hallmark diseases here: CML, polycythemia vera, essential thrombocytosis, and myelofibrosis. Usually these are older patients. Marrow's hypercellular, and many of these patients do have the JAK2 mutation. The JAK2 mutation is a protein kinase, and if you have this mutated, it leads to uncontrolled cell growth. Almost all of the P. vera patients have JAK2, and half of the essential thrombocythemia patients have JAK2, but not CML. With CML, it's the BCR, ABL, or Philadelphia chromosome. So let's talk about CML. This Philadelphia chromosome, again, this is another mutation leading to uncontrolled growth. We have tyrosine kinase inhibitors, imatinib, and then some newer ones as well. This has really been a revolution in not just oncology, but in all of medicine that has enabled people with CML to live 20 or 30 years, and some even be cured now with these oral drugs. But for your purposes, know how they present. So these patients will have some constitutional symptoms, some hepatosplenomegaly. They'll have a high white count, but the key here is they'll have a high white count and they'll have a little bit of everything, like we just saw. So you'll see promyelocytes, myelocytes, metamyelocytes, maybe a few blasts, eosinophils, basophils. When you see that sort of smattering of everything in a high white count, think of CML. And they can have an elevated platelet count as we saw in our case. And so this is just what a smear looks like in CML. You can see that purple represents the myeloid cells, and there's just way too much purple here, much more than you're used to seeing on the smears that I've shown you. And you're seeing a little bit of everything: myelocytes, neutrophils, bands, right? Here's a band. So there's just a little bit of everything on the smear. So what are the take-home points here? We've kind of covered all of this: the 922 translocation, the tyrosine kinase inhibitors are first-line treatment. And so this will be typically a middle-aged or older person, again, with a high white count and a little bit of everything on their differential, and maybe a few blasts, but not too many. Just a word or two on some of the other myeloproliferative diseases. Polycythemia vera, this is too many red cells. Why do we worry about this? Well, because these patients can have trouble with thrombosis and conversion to acute leukemia. If they want you to find this, they're going to give you an older patient that maybe has some vasomotor symptoms, have itching after they take a bath. Aquagenic pruritus is kind of one of the things that we think about with P. vera, and enlarged spleen. And then on their CBC, their hemoglobin will be like 19.5. And that's when you want to think about P. vera. As we said, almost all of them have the JAK2 mutation. Primary treatment for P. vera, if you're lower risk, it's just phlebotomy to lower your hematocrit. If you're higher risk, we can use medications like hydroxyurea. Essential thrombocythemia, same concept, but it's platelets now, too many platelets. Main thing here is if they give you a case and the platelet count's 850, rule out a reactive cause. Remember we talked about how iron deficiency can cause high platelets. If you've ruled out a reactive cause, you diagnose ET. Again, same complications, thrombosis and risk of evolution to leukemia. So treatment can be the same hydroxyurea to lower the platelet counts. But here, again, it's more about recognizing, I think, the diagnosis. So how about lymphomas and leukemias as we're kind of hitting the home stretch? So we talked about some acute leukemias, but now we'll go into some of the primarily CLL when I say leukemias. But so these lymphomas, CLL, you can have lymphadenopathy, constitutional symptoms, various complications. If you're suspecting lymphoma, you need to do an excisional biopsy, not an FNA. You do staging imaging studies, CT, PET, bone marrow biopsy. And then there is a lot of treatment implications depending on what type of lymphoma you have. And so for that, I would circle this chart as something to give you some familiarity with. There's basically two categories of lymphomas within the non-Hodgkin's. You have indolent. These are typically older patients, minimal or no symptoms. These are incurable lymphomas, and many times you just watch them and you treat them later. And so examples here are follicular lymphoma, marginal zone lymphoma. And then you have aggressive lymphomas. These can be younger. They're usually sick by the time they come to you. These can be cured, and they require immediate treatment. And that's like diffuse large B-cell lymphoma, Burkitt's, and mantle cell, just to name a few. So thinking about it conceptually, there are some differences there. Some associations here, which you can look over on your own. Burkitt's is one that shows up a lot because it's so different. This is a very aggressive non-Hodgkin's lymphoma, very rapid growth pattern. These patients often develop tumor lysis syndrome because of the rapid cell turnover. And there's an 814 translocation that's seen in Burkitt's, and this had been associated with HIV/AIDS a lot in the past as well. All right, our next question. A 79-year-old male is noted on a routine physical with an abnormal CBC. He has mild fatigue, mild lymph node enlargement, and mild splenomegaly. His white count is 68,000, and lymphocyte is 61,000. Hemoglobin's 11, platelets are 82, and you see the peripheral smear there. What is the most likely diagnosis? CML, CLL, AML, ALL, or my favorite, huh? What do you guys think? All right, fantastic. So 80% of you correctly recognize this is what CLL looks like. So with CLL, this is often somebody that's diagnosed incidentally. These patients are not sick. This is probably the gentlest of all the leukemias, as I tell my patients. They'll have a high white count, older patient, mostly lymphocytes, and they feel pretty okay. And so this slide talks a little bit about how CLL is within a spectrum. It's the same cell that could be considered lymphoma, which is small lymphocytic lymphoma, if most of it's in your lymph nodes. But if most of it's circulating in your blood, then it's considered CLL. And as I said, older patient, lymph nodes, enlarged spleen, mostly lymphocytosis. So you see, if this were CML, it would look different because the patient would be a little sicker, and instead of most of that WBC being lymphs, you'd see a little bit of everything. Metamyelos, myelos, promyelos, that's how you're going to easily differentiate CML from CLL. And you can see here, you have a lot of these mature lymphocytes, but these ones are the same size as a red cell. So you know these aren't blasts, right? Because they're not too big. So you won't look at that and think, oh, he's got blasts. And these little pinkish purple things here that I showed you on the question, these are smudge cells. If you see smudge cells, think CLL. Make that association. Basically, these lymphocytes, there's so many of them, they're fragile, that when you prepare the slide and you put the cover slip on, some of them break. And that's what these smudge cells are. It's an artifact, but it's pathognomonic of CLL. And this summarizes some of that. Hairy cell leukemia. This is another sort of indolent leukemia, older males primarily. And what you need to know here is these patients present with pancytopenia, an enlarged spleen, and they have a dry tap. And what that means is when they do a bone marrow aspiration, we're not able to aspirate any fluid. It's called a dry tap, and it relates to fibrosis in the bone marrow. These leukemias have a pretty good prognosis and high remission rates with chemotherapy agents such as cladribine. So I'll stop for just a second here, and let's do a quick pancytopenia review. So if you have pancytopenia in a young patient and a hypocellular marrow, no cells in the marrow, that's aplastic anemia, right? If you have pancytopenia in an older patient and there's a lot of cells in the marrow, that's MDS, myelodysplastic syndrome, right? Older patient, hypercellular, a lot of cells, but they just can't make them they can't produce them effectively. That's MDS. If you have pancytopenia and you do have a significant number of blasts, then you have to think AML or ALL. And then you look for that hour rod for AML. If you see DIC, then you know that's that one subtype of AML. If you see cranial nerve palsy, CNS, lymphadenopathy, then you know it's ALL, right? So that's how you think. And then if you've got pancytopenia, no blasts, but a dry tap, then you think of this hairy cell leukemia. Okay, and this is just a picture of what the hairy cells look like, these cytoplasmic projections that arise that you won't miss if you're shown it on a smear. Hodgkin's lymphoma, so this tends to have a much better prognosis than non-Hodgkin's lymphomas. Can happen in younger patients, often with asymptomatic lymphadenopathy and sometimes some of the other symptoms and signs that you see here. Again, lymphoma rule, you always diagnose by excisional biopsy. And here what you're looking for is the Reed-Sternberg cell. That is this bilobed nucleus, which they refer to as the owl eyes. If you see this on a smear, you think of Hodgkin's lymphoma and only Hodgkin's lymphoma. Treatment is based on stage, but usually involves some combination of chemotherapy and radiation. The chemotherapy regimen that you should know is ABVD, and the individual drugs, and we'll talk about this next hour in oncology, but adriamycin, bleomycin, vinblastine, and dacarbazine. The prognosis, thankfully, is pretty good, even with stage 4, 60% long-term survival rate. And I think one of the most common areas where I see questions in Hodgkin's for an internal medicine board exam relates to late complications of therapy. Because so many patients are cured, they show up in your clinics 2, 3, 5 years later with complications. So what could that look like? So if they give you a young Hodgkin survivor who a few years ago had radiation to her neck, and now she presents with hair loss and weight gain and fatigue, check a TSH, think about hypothyroidism. That's your next step. If they give you a young Hodgkin survivor who presents a few years later with a dry hacking cough and dyspnea, think about pulmonary toxicity from the bleomycin. If they give you somebody who has cardiomyopathy and premature cardiac failure, think about the adriamycin and cardiomyopathy, late complications of therapy. Radiation to the chest, premature coronary disease. Radiation to the chest, higher risk of breast cancer. So you want to screen them more aggressive. These late complications are where you really may see something as it pertains to Hodgkin's. Okay, this is our final AR question of the hematology section. I give you a 54-year-old man. He had a history of prostate cancer, let's say 5 years ago. It was early stage. He had it removed surgically. He has fatigue and exertional back pain for 2 months. Exam shows normal straight leg raises and downgoing toes. So fatigue and back pain, and this is what his lab profile looks like. So let's hit the highlights. A mild anemia, creatinine's up to 1.7, total protein's 8.5, albumin's 2.9, calcium's a little high at 10.4, and some protein in the urine. Back pain. Which of the following is most likely to diagnose the cause of this patient's back pain? Bone scan, PSA, SPEP and UPEP, lumbar spine radiograph, or MRI of the lumbar spine. What do you guys think? Very good. So 81% of you correctly guessed SPEP and UPEP. And the prostate cancer is really just a distractor here because the lab abnormalities tell you that this looks more like a myeloma type of process. and the fact that you knew that was the last part of the section that we hadn't talked about yet. So that always helps. Plasma cell disorders. I'm just kidding. Plasma cell disorders. Myeloma. Myeloma is the acronym of CRABS: hypercalcemia, renal insufficiency, anemia, and lytic bone disease, right? And so to diagnose symptomatic multiple myeloma, you must have evidence of the organ damage that I just reviewed with you, and you must have at least 10% bone marrow plasma cells involved. And this requires immediate therapy, and there are specific drugs that we use. Lenalidomide, bortezomib. There's been an explosion of new drugs in this arena. But that's myeloma. But this is a spectrum, and myeloma is all the way at the end. What's at the beginning of the spectrum? You should recognize MGUS, or monoclonal gammopathy of unknown significance. And so here you have a monoclonal protein, but it's not causing any damage, and it's only a very small amount. So there's no organ damage. These patients have about a 1% per year risk of progressing to myeloma. So you have to watch them, but you don't have to treat them. And so you just do annual follow-up. So don't trip up on a patient where they give you an M spike of 1.2 and you say, oh yeah, this looks like myeloma, but there's no organ damage. You don't treat that patient. Smoldering myeloma is where you have maybe a little bit more of that M protein, but you still have no organ damage. And in this case, they're at higher risk of transformation, 10 to 20% per year, so you watch them closer, but you still don't treat them. So here, every 3 to 4 months with labs and H&P. So recognize that in order for it to be real myeloma, you have to have the organ damage and 10% plasma cells. Recognize that myeloma is different from Waldenstrom's. So in Waldenstrom's, you also have a monoclonal spike, but it's IgM in Waldenstrom's. And so I remember that by taking the W of Waldenstrom's and flipping it upside down. So Waldenstrom's is IgM. If they're giving you an IgM spike, think about Waldenstrom's. And this disease kind of behaves more like a lymphoma, where you get organomegaly and you can get hyperviscosity from this IgM because it's a very viscous, thick molecule. So this again summarizes myeloma. The M spike, 10% plasma cells, you got to have the organ damage. Commonly, as in our case question, they'll ask you what's the initial step in workup. It's going to be SPEP and UPEP. You do a skeletal survey to look for lytic bone disease and eventually a bone marrow biopsy. And we did speak a minute or two about some of the systemic therapies, and in younger patients, we still do autologous stem cell transplants. So that concludes the hematology discussion. You guys were great. It was a lot of material to get through. Thank you guys so much for your attention. I appreciate it.